There are a number of possible reasons why you may need to come to the critical care unit. And of course, every patient's experience and critical care journey is very different. We recognise from sharing events and clinic consultations that you will share some similarities with other patients. We know in the past that some patients will have welcomed the opportunity to have come to the critical care unit to see the environment that they were looked after in, and to make sense of some of the surroundings, maybe to hear some of the sounds and maybe even to see a familiar face. Unfortunately, in these times, that's not possible. So we've put together a short tour and informative video of the critical care environment, and we hope that you can watch it with your family and friends, and hopefully it will help fill in some blanks and help you on your journey to recovery.
Hello, my name is Maddy. I'm one of the nurses here on critical care. I'm going to give you a tour of one of our bed spaces. All of our bed spaces look exactly the same. During your stay, you may have had a specialist tube put down your windpipe, which is one of these here. This allows us to help you to breathe. You would have also been attached to one of our ventilators, which is over there, and they are all exactly the same. When you were ventilated, you would have had sedation, which meant you would be able to tolerate the tube and you would have been asleep. So after you had this tube, you may have also had a tracheostomy, which is one of these here. These would be put in your neck here, and this means that we can turn off the sedation so that you can be awake whilst you're attached to the ventilator. During your stay, you may have been attached to lots of different machines. This machine here records your vital signs, which is your heart rate, your blood pressure and your oxygen levels. You would have also been attached to our computer here, which is where we record all of our documentation. You would have also been attached to our fluid pumps here, which allows us to give you lots of different medications. You may have had lots of different lines inserted. So for example, you would have had an arterial line, which may have been in your wrist. This allows us to take blood samples and record your oxygen levels. It also allows us to record your blood pressure. You may have also had a central line or a vas cath inserted into your neck. One of them allows us to give you strong drugs and the other one allows us to give you dialysis. You may recall lots of different noises and sounds. For example, our dialysis machine. This is very noisy and also uncomfortable. Some of the other machines that I've spoke about also make lots of noises, which you may recall. Whilst you're a patient here, you may have also had a specialist tube which would go down your nose and into your stomach. That's this tube here. This allows us to give you some special food and also your medications. You may also recall lots of different nursing interventions. One of them would have been regular repositioning, which would have prevented you from getting pressure sores. As you were getting better, we would have also started your rehabilitation. You may recall us getting you out of bed into a chair, which would help you to get better.
During the peak of the pandemic, many of the practices changed in critical care, the main one being when our patients arrived, they were already sedated and ventilated. Staff also faced challenges. These included wearing full PPE. Full PPE for our staff meant that they were wearing hats, visors, masks, full gowns and gloves. This presented many challenges for staff and patients, but mainly for patients, they were unable to recognise the staff who were looking after them on a daily basis.
So the main roles and responsibilities of the critical care outreach team are to look after deteriorating patients on the ward. So we will receive referrals from doctors, nurses, other healthcare professionals. We will go onto the ward and provide support to that ward and bridge the gap between the wards and critical care. We prepare patients to leave critical care by visiting them on the critical care unit. We will provide them with information, literature to help transition that move onto the ward and make it just a little bit easier. We will also visit patients on the ward within 24 hours of discharge from critical care and just make sure that everything is how it should be and follow up on any concerns from the patients. Critical care outreach will assess patients on the ward by looking at many different things. So we will use tools to assess psychological impact from stays in critical care. We will also look at clinical things such as bloods, x-rays and other tests. Mainly we will liaise carefully with your parent team and bridge the gap between critical care doctors and also the doctors who are looking after you on the ward. While stepping down to the ward from critical care can seem like a positive step, sometimes patients can feel like a safety blanket has been taken away and feel quite lonely. Critical care outreach team aim to bridge that gap between intensive care and the ward.
As a speech and language therapist working on critical care, you may have interacted with us having some mouth cleaning, having your teeth brushed. We may have also started introducing food and drink during your stay and talking to you about how your swallow may have been affected. We might have also helped you communicate with loved ones or just find a way to get your voice back. There are multiple reasons for oral care and brushing people's teeth during a hospital stay. One is for comfort. As you can imagine, if you didn't brush your teeth, it can be quite uncomfortable. Also, you can get quite a lot of bacteria that builds up in the mouth, and that can be unsafe if it goes down the wrong way onto the lungs. It can cause an infection. So it's really important that we keep mouths nice and clean. During a hospital admission, especially on critical care, patients may have a tube to help them breathe, and that means that they can't express themselves and they don't have a voice. Speech therapists are experts in finding people's voices and helping them recover once that tube is removed. So the removal of a tracheostomy can be a very gradual process, especially people who have been critically unwell. It requires a lot of different professions to be involved, speech therapists, physios, physicians, in order to make sure that's a safe and effective process. Patients who have been on critical care might also find that they're a bit weak and tired, and that can affect their voice or communication in various ways. And we might have helped them find other means of communication, for example, using their telephone, writing, or using a chart to help them communicate.
So with the physiotherapist, we would speak to your family and people close to you to find out who you are as a person and to find out the things that are most important to you and how you were before you became unwell. And then we would engage in the rehabilitation process together, setting goals. Physios will probably focus more on the physical side of the rehabilitation, and OTs will focus more on the functional activities and the cognitive side of the rehab process to prevent you getting stuck in any uncomfortable positions and to support your engagement and function once you wake up. If you've been sedated during your stay on critical care, we would facilitate sensory stimulation for you to help keep you engaged in what's going on around you. It can also be used to give you pleasant sensations during your engagement, as usually on critical care lots of the sensations that you feel will be quite negative or uncomfortable. So things like having your blood taken and having your NG tube changed, for example. So we would give you an opportunity to have positive feelings. OTs will monitor closely your upper limb function. Because you'll be lying in bed for a lot of the time on the unit, it's not unlikely that you will become a little bit stiff in your hands and upper extremities. So OTs will be involved in prescribing and making splints for your hands and upper limbs if needed to prevent your arms from getting stuck in uncomfortable positions, which will then limit function later on. During your stay on critical care, it is quite common for people to have feelings of anxiety or stress and also to have reduced endurance to engage in activities. So together with you and your family, we will have set a fatigue management program to help you engage in activities that are important to you once you leave the unit.
During your stay in critical care, you could have been extremely unwell, wouldn't have been able to eat and drink at all. So this is where we come in and would provide enteral nutrition, as we call it. So that's just a little simple NG tube, a little tube that goes through your nose and into your stomach. And it could have even been in some cases where we can't use your stomach or your digestive system at all. We would have been able to feed you directly into your bloodstream. So in those sort of cases, you would have been sedated and ventilated, and we would have made sure that we would have given you nutrition in a different route of nutrition. The role of a dietitian within a critical care setting is definitely very important, because a lot of people, I suppose, don't think about that you need to be nourished, you need to be hydrated while you are extremely unwell. If your condition changes, your nutritional needs will change on a daily basis. So we as dietitians are specially trained to adapt your nutrition plan very quickly and on a daily basis. So as soon as you move from the critical care unit back to the normal wards, even back into the community, by that time you will probably have been able to eat and drink again, but you might still face some ongoing problems with a reduced appetite or just not feeling like eating at all, even sometimes having some swallowing difficulties. And in the community also we've got plenty of dietitians who will follow you up and see how you've been getting on after you've been discharged from hospital. And who knows, you might have even been taking off those supplements because you were doing so much better, or you might need to for a little bit longer just to get back to normal again.
My job and my team's job is to come and see you when you're critically unwell and help you because you're in a situation where probably getting out of bed is the last thing that you want to do at that time. So if you're in bed for a long time because you can't get out of bed, and that may be due to the equipment that you're attached to and how well you are in terms of things like your blood pressure, we know that you can lose 2% of your muscle mass for every single day that you're in bed, which can for some people make them extremely weak. And also there may be other things that we need to consider, such as how often we can move you, because if we don't move you enough you can have problems with your skin, and also you could potentially develop blood clots in your legs. So it's very important that we move you as much as we can. We are also aware that you may have problems sleeping. There are lots of noises in critical care, and when we first approach you to come and move, quite often you will feel tired, but we know by actually doing more physical activity will help you get back into your normal patterns of sleep and actually make you feel a lot better within yourself because you're exercising and moving. Sometimes we can't ask you how you normally move, so we will ring your relatives and speak to your relatives about how you normally move, and that really helps us to be able to set goals for you and with you which are realistic to your abilities. When you're sedated, for some people, we will come and do some stretches with you. When you're not even awake enough to be able to join in, we will move on from that and help you do exercises in the bed. And for some people, just practicing rolling in the bed will be all that you can manage. As you get a little bit better, we then will go and help you sit on the edge of the bed. And for some patients, we'll actually lift you out via a hoist into a chair for a short period of time. Further on, some patients will be able to actually walk short distances with lots of support, and you may need to use some walking aids such as a stick or frame for a short period of time to help you recover. Physiotherapists can also help with breathing problems. It may be that you have some phlegm on your chest, that you need some advice in order to help you cough and clear that, because if you've been weak that can be difficult. You may need some advice to help you with breathlessness, and also we want to give you some confidence to help you breathe as you're coming off the ventilator in some cases, and to breathe for yourself. We know it may take many months for you to recover and potentially to go back to work in some cases, and physiotherapists will be with you along the way, continuing with your goals until you get to the ability that you need to go forwards.
Thank you very much for coming to this clinic. The reason why we have this clinic is because we found that although we are very good at getting people over severe critical illness, we found that the actual recovery period, both psychologically and physically, can be a very long time. So this clinic is part of that recovery process in order for you to complete your journey from that critical illness. I will be asking you a series of questions and we'll go through a little bit about why you came to intensive care and what we did on intensive care. The doctor will be asking a list of questions about your stay on intensive care and your recovery since. These questions may well be about hallucinations or nightmares or flashbacks. They may well be interested in your global memory function and how you feel as though your brain is working now. They will ask you about your muscle strength, weakness and your ability to exercise. Other factors will be any degree of shortness of breath or reduction in your lung function. They may well ask you about swallowing or speech problems since your stay on intensive care. They may well ask you about how you're sleeping and also whether there are any signs or symptoms of a depressive illness. So if I can try and explain to you the reasons why you had some of these feelings, I hope that would help. Your worries over confusional states and delirium is extraordinarily common on intensive care, and this is caused often by the drugs that we need to use in order to sedate you on intensive care, but it can also be just as a result of the illness itself, and also as a result of things like loss of your day-night cycle, lack of sleep. All of these will contribute to it. The nursing staff are fully aware that many of our patients are confused, and this is something that we deal with on a daily basis. All of these nightmares, flashbacks and hallucinations will improve with time. In terms of breathlessness, this is incredibly common after intensive care. The lungs have been inflamed, and there will be a degree of scar tissue and fibrosis within the lungs that may well increase your sense of shortness of breath. All of this still has the chance to improve with time and exercise. In terms of the muscle weakness, this is again as a result of both the illness and immobility on intensive care, and this will have affected all of the muscles in your body. This again will improve with time and exercise. I always say that there are 5 treatments for many of the problems that you've described. They can start with very simple treatments like lots of contact with friends and family. Unfortunately, exercise is one of the mainstays of treatments. Not severe exercise, mild exercise within your limitation, with an aim to slowly increase activities. Good diet, good weight control, and if you're diabetic, good sugar control will also aid in recovery and reduce the risk of further infections and complications. Returning to work is a very important aspect of the recovery pathway, as well as resuming hobbies and other stimulating activities. The final treatment option that we have for patients who have severe depression or anxiety symptoms associated with the recovery would be an antidepressant tablet or cognitive behavioural therapy. But I feel that the other modalities should all be tried first in the recovery process.
So though many patients do suffer significant physical and psychological symptoms after a period of critical illness, remember simple measures can be very effective in combating this. These include contact with friends and family, regular, non-strenuous exercise, good control of diet and weight, and in diabetics, good glucose control. A return to work and hobbies is also a very important factor. Only after these simple measures have failed would one consider using antidepressant medications or cognitive behavioural therapy as an adjunct to the treatment.
We hope you found this video helpful on the road to recovery. Further information and support can be found online.